Hello everyone, welcome to our live session today. I will be going over a quick startup presentation to welcome you all and introduce you to our program and the opportunities we have if you have not previously attended our pre-health shadowing sessions. Pre-health shadowing is a student-led, minority-led, and women-led nonprofit dedicated to help prospective healthcare professionals gain access to educational resources no matter their demographic, status, abilities, or location. My name is Muntaha, and I am the editor-in-chief here at Pre-Health Shadowing. Thank you all for attending today, and let's get started with today's virtual shadowing. So a little PSA, we do have closed captioning for all of our sessions to accommodate all students. This setting is available on the bottom of your Zoom screen, and if you do need assistance enabling the transcript, please direct message one of our team members or myself, and we are always looking forward to make our sessions more inclusive and ensure that our sessions are accessible to everyone. So please, if you have any recommendations for improvements, please do email us at info@prehealthshadowing.com. So since this is an international program, we want to know where you are all Zooming from. Drop it in the chat, and I'm actually calling from Florida. It looks like we have so many people around the country. Nice. So if you want to stay in the loop, follow us on our social media. We are active on Instagram, we have a TikTok page, or you can sign up for our email list on our website to never miss a session. We have some wonderful opportunities for you all as benefits of being part of the pre-health shadowing program. We do have a partnership with Kaplan to get our students a 10% discount code that can be used on all Kaplan products, as well as free resources, such as study guides to help prepare you for standardized tests that pre-health students take, such as the MCAT, NCLEX, or PCAT. If you fill out our short survey in the chat, we will get you signed up for these deals for absolutely no cost. We would also like you to draw our attention to the Neolith, which is an online mental health program for students, college, and young adulthood. It's really stressful, even in non-pandemic times. So for pre-health professionals especially, we know that the path is not easy. That's why we have partnered with Neolith to spread the word about mental health and offering free service and access to their mental health services. There's a link in the chat to enter the code PREHEALTH when signing up, and you are able to access Neolith services. Mask for Mask is an amazing women-led organization that donates 4 masks for every 4 masks sold. These go to people in need during the COVID-19 pandemic, those in the homeless community, healthcare workers without proper PPE, and others who are struggling to stay safe during the pandemic really do need these masks. So with our discount code PHS15, you can get 15% off of your mask order. And if you buy through this method, pre-health shadowing will also get 10% of the proceeds, which is amazing because we are a nonprofit that runs solely off the support of our wonderful community. If you want to play a bigger part in supporting PHS, we would love for you to join our network of student volunteers and team members. You can apply to be part of our administrative team and lead students in various projects and initiatives with professional outreach, grant writing, and so much more. We understand that as pre-health students, you may not have the time, so we do offer the opportunity to volunteer asynchronously with tasks that can be done on your own time. We would love to have you be a part of our program and contribute to your own unique perspective. If you are a high school student and want to get involved, we have started a program called HTP, which stands for High School Training for PHS, which allows you to connect with college pre-health programs, get involved in fundraising for PHS, and organize resources for other high school students interested in medicine through pre-health shadowing. We want to recognize the hard work of all of our students in the program. So if you are interested in getting published, you can submit essays, reflections from our shadowing sessions, research papers, articles, and reviews to myself. I'm the editor-in-chief. There's a link dropped in the chat to have your work on our website. This will look great on CVs, applications, resumes, and etc. So please take advantage of this. Part of our mission is to promote diversity. In order to do this, we have launched an initiative to have monthly panels to celebrate different demographics in the field of medicine. Some of these are upcoming events, including a series on patient experiences, a COVID-19 roundtable, international student forum. If you have a mentor, professor, or professional that has inspired you and you think they could contribute to these conversations, please nominate them today using the link in the chat. We can humbly ask that if you would like to keep our program running and you are able to, please donate to Pre-Health Shadowing. As you know, Pre-Health Shadowing is completely student run. We are working around the clock to keep this free and accessible to everyone. So unfortunately, Zoom and our website are not free, so any contribution you can give would be greatly appreciated. If you are not financially able, we request you to send this link to someone you think who can support us with these opportunities we have at Pre-Health Shadowing. So throughout the session today, we encourage you to drop any questions you have for the speaker in the chat, and our team members will be making note of these to be asked in the latter half of the session. You can take good notes as our professional is going over their presentation. There will be the chance to take a post-shadowing assessment in which you will have to answer 10 multiple choice questions to verify your virtual shadowing hours. More information on this will be available on the latter half of the session, so stay tuned. Lastly, if you can, we request you turn on your cameras. This is by no means an obligation as we are respectful of different circumstances, but it does help us feel closer together at a time when socially distancing is mandatory. I appreciate you for listening, and now I would like to welcome our professional. Thank you so much for joining us today. You may share your screen whenever you're ready. Today we have Terri Thompson, who is a labor and delivery nurse presenting for us today.
Sorry about that. It just clocked out. Let's try it again. Okay, can you hear me now?
Yes, we can hear you and see you.
Sorry. So I am Dr. Terri Thompson. I am first I'd like to give you my disclaimers. I have received no financial compensation for the presentation. Anything I talk to you about is from me. Any personal photos or photos that I took myself, I got permission from those who I took them from. Although I work for California Baptist University, I'm not sponsored by them for this presentation. And then any scenarios that I came up with could be related to some patient condition, but there's no patients that you would be able to identify because of HIPAA. All right, so why I chose to be a nurse? Well, you know, we all think sometimes when we're younger, this is what we know what we want to do, and then we may say, you know what, I don't know what I want to do, and you toss everything around and you have all these options. But for me, I chose nursing because when I was 16, I took a health class in high school, and my teacher gave us a CPR class. And I got my CPR card in the mail. And the very next day, I was late for school. I came downstairs and I found my father slumped over on the couch, and he had a weak pulse. He was unresponsive. He had a lot of histories. He's had a couple heart attacks, a stroke. And so I had to call 911, and I had to call my mother, and these are my parents. My mother was actually a phlebotomist, and she would be waiting in the emergency room for him when he came in, not knowing that he was coming. So I had to remain calm. I had to call everybody and let them know. I had to call the hospital, my mother. When I arrived to the hospital, the ER doctor spoke to me and he said, you know, you remain calm and you did such a good job. Have you ever thought about being a nurse? And I had thought about being a nurse, but at that point I decided, you know what, I think I do want to be a nurse. And these two people right here, they're very encouraging, and they supported my decision and were my biggest cheerleaders. So as far as my education, I am from Oregon, but I went for my undergraduate in Tulsa, Oklahoma at Oral Roberts University, where I got my bachelor's of science in nursing. And then I decided that I just wanted to be a bedside nurse for a long time. That's all I wanted to do. And then 23 years later, I decided that I wanted to do more. And so I got my master's at Chamberlain College of Nursing, and I did my master's online. And I got my master's of science in nursing with nursing education focus. And then I got a job at California Baptist University, and I got my doctorate. DNP is Doctor of Nursing Practice with the emphasis in education. And I got that at Western University of Health Sciences in Pomona, California. So as far as extracurricular, when I was getting my bachelor's degree in Oklahoma, I worked as a nurse assistant at a Catholic hospital in pediatrics and in postpartum. I also worked at another faith-based hospital in postpartum and labor and delivery, and I loved both those areas. I thought that this was a great place to be. So I did a year and a half of surgical trauma, intensive care as a new grad. And then I did 8 years in the emergency room at a level 1 trauma center. And then I decided that I wanted to retire in labor and delivery. So I have worked in labor and delivery for 23 years. I returned to, when I returned to get my master's, I received a nurse educator scholarship because when you've been a nurse for more than 5 years, they were willing to give you extra scholarship to come back and get your master's. I was a National League of Nursing member. I was an International Board Certified Lactation Consultant. I also am in Sigma Theta Tau International Honor Society for Nursing. I'm the counselor for the chapter at my school, for the Chi Mu chapter. When I was getting my doctorate, I won a summer research scholarship for my Doctor of Nursing Practice project, and I did my nursing practice project on Preconception Health Education and the focus of the importance of getting preconception health care prior to getting pregnant. And then I was also in a Doctor of Nursing Practice Association. So try to be involved as much as you can. I have 4 children and work full time, and so you can only spread yourself so thin, so you do what you can. The reason I chose labor and delivery, it was my favorite rotation in nursing school. I loved it. I loved seeing women have babies. I loved caring for the family, watching the dynamics of all the family members, how they thought this new little family member was so amazing. And I thought, it was just awesome. I love pregnancy. I love pregnant women. I love caring for and helping women who are in labor. Every labor is unique. Everybody has their own idea of what labor is. And it's just amazing to watch as this family is preparing for their new child. I love watching the siblings welcome their new little sibling. You know, you don't know what the baby's going to look like. Everybody speculates, and then it gets here and you see these big dads just tearing up and crying. It's really beautiful. Because I worked as a patient care assistant in postpartum and labor and delivery, I had exposure to this area, and this is where I decided that I wanted to do. I knew that this is where I wanted to end up at the end of my career. So this is where I decided to retire. I wanted to start somewhere else in the intensive care areas, the ER, because I wanted to have other experiences before I moved into labor and delivery. I thought that that would help me and make me be able to recognize more critical things that happen with mothers and babies. So my personal definition of my careers is in nursing, you care and connect with people for varying health issues and circumstances. You want to make a difference. You like people. You want to figure out what's going on with your patient. And nurses spend a lot of time at the bedside. They are there with the patient. They're there with the family. They're able to see changes that are occurring. And it's like putting a puzzle together. You're trying to figure out what's missing or what you can do to make your patient more comfortable. I like to provide holistic care to women, infants, and families, and give the best care in the worst circumstances. When I worked in the ICU and the ER, there was a lot of poor circumstances. There was a lot of really ill patients. A lot of them didn't make it. When I came to labor and delivery, that's happy nursing. Most of the time it's really happy. When it's happy, it's really happy. And then when it's sad, it's very sad. But the benefit is I get to deliver babies every day. And that's the best part of being at work. So I am also an educator. So I'm still working as a labor and delivery nurse monthly. I work a couple times a month, and then I work full-time as a nursing educator. And I love being a nursing educator. I love having some influence or some interaction with these future nurses. I get to see the excitement that they see when they figure things out, when they're learning. All this information is not new to me, but it's very new to them. And it's exciting to watch that. It's exciting to watch them transform into a new student and then getting ready to transition into their nursing practice. And I get to teach the favorite subject, and every student loves OB. Even if they don't want to work in there, they still love it. And so the highlight of my career is watching each nursing student who finishes in their 6th semester. I watch them get pinned. And what that means is they get initiated into nursing practice. It's like a rite of passage. We welcome them in. And then I get to watch them graduate. And I get to work with a lot of my previous students as my coworkers. And so that is a lot of fun. I love that part. So as a bedside nurse, it's a profession of trust and respect. We get the opportunities to care for others, for patients, families. You get to see how every family dynamics is so different. You get to promote the health of your patients. You get to educate. And education is a lot of fun, and they have a lot of questions. And even if they've had a lot of babies, they still have uncertainties. So it's nice to be able to create a bond with your patient. You get to work closely with other members of the healthcare team, the unit secretaries, the techs, the other nurses, the healthcare providers, physician assistants, nurse practitioners, doctors. You get to see the families at their lowest times and their happiest times, and you get to be a part of that, and they remember you. Nursing is not glamorous. It's not like Grey's Anatomy, and you work long hours. They can be very vigorous and rigorous, and you can be on your feet for 12 hours, and you can be physically and emotionally drained, just exhausted. But then there's days where it's so rewarding because you get to provide care for others. A normal day for me is I am involved in many deliveries. I get to attend C-sections. I may attend emergencies, and then I might just attend a patient who I'm caring for that's not delivering. So my typical day, I have to clock in at 7 a.m. We have to change into scrubs because we have to make sure that we're clean. All our environmental, all the environmental factors that jump on your clothes when you're just walking are off. We go to a pre-shift meeting. So we meet, get our assignment for the day. We go get a report. And then once we get our assignment, we'll determine what we're going to do. So it could be, I could get assigned to go for a C-section. I could be assigned to take care of high-risk pregnant patients who are going to stay pregnant, or we're trying to keep them pregnant. I can take care of laboring patients, those who are pushing, and I can take care of patients who just had their baby, and I'm watching them bond. I'm helping them breastfeed, and then I transfer them to the postpartum unit. I stay until 7:15 p.m. until I give report. I change my clothes, and then I clock out. So it sounds like a pretty easy day, but it can be very busy. Some days are busy and other days are not busy. So it just depends on when babies decide they're going to come. As far as being an educator, I get to teach students. These are actually 2 of my male students. We do what's called simulation. And so we We give them a scenario, they create the scenario, and they put their own kind of personal flair on it. And so one of them decided that he wanted to be the laboring mother. I get to offer them feedback, direction, give them constructive feedback. I get to mentor, which is a lot of fun. I keep track of my students. They always come back and visit. I teach in the 3rd semester out of 6 semesters in a bachelor's prepared program. I offer guidance to students preparing for practice. I create the syllabi, the teaching plans, the tests and quizzes. I like games, so we do a lot of games. We do Kahoots, Bingo, as far as learning in my course. I'm involved in clinical and simulation, and then I evaluate student progress. So typical day as an educator, I get in at 6 a.m. I teach 2 classes on a Tuesday and 2 classes on a Thursday. On the Tuesdays, I have 1-hour classes, and on Thursday, there's 3 hours each. I have office hours, about 8 to 16 hours per week. I make lesson plans, post tests. I help students who maybe have a little test anxiety. And you can see that dog right there. That is our therapy dog, Ruger. And if my students get a little nervous about taking an exam, we call Ruger in. And they get to pet on him. He's a Labradoodle, pretty big, very sweet, very calming. And so that's another fun part of my job, is that we get to visit with Ruger. So I want to talk about pregnancy. How many of you know about pregnancy? You've seen pregnant women, right? You see them all around, and when you're paying attention, you probably see more than you do when you're not paying attention. But I want to know, how much did you weigh at birth? How much did you weigh when you were born? And then how many months or weeks is considered a term pregnancy? So when you get a due date, how many months are you pregnant? Are you supposed to be pregnant? And then how many of you were born prematurely? Oh, here we go.
So for the first question, I have a poll up if you guys can answer. All right, let's see. So if you guys can see the results, the majority is 7.5 pounds.
7.5. We do have a few 10-pounders and a few 5-pounders. And so 7 to 8.5 is considered average size. If you're 10 pounds, 10 pounds, that's considered large. And if you're under 6 pounds, that's considered small.
Let's see who was born early. All right, go ahead and stop it.
Okay. So some of you aren't sure, so you can be asking your mothers. So now that we have this lecture today, you can go home and say, tell me when I was born. Some of you were carried to term or later, and then some early. Okay. And we're going to talk about what term is and what early is. All right. So our next poll, let's see. Okay. How many months or weeks are considered term?
We'll give it 10 more seconds so everyone can get their answers in. It seems like the majority is 40 weeks.
Good. And it's 40 weeks, and that's what we base it on. And so 42 is overdue, but it's still term, and 37 is the early part of term, and then 36 is preterm. Good. All right. So We know who was born early. We know who was born late. So let's look and see. When we figure out how is, we look at the first day of her last menstrual period. And I'm going to show you an easy way to figure that out without looking at the calendar. So you take what's called Nagel's rule. So you take the first day of her last menstrual period. So if her period is December 12th, okay, you subtract 3 months and then you add 7 days. So example, if her last menstrual period is December 10th, okay, December is the 12th month. So we're going to subtract 3. So 12 minus 3 is 9. So that would be the month September. Then we're going to add 7 to the days. And so it was December 10th. So 10 plus 7 is 17. So her due date would be September 17th next year. And so that's how you do Nagel's rule. So now it's your turn. Her last menstrual period was October 20th. When is her due date? So her due date, see if you got it right. So 10, October's the 10th month, minus 3 is 7. So that's July, the 7th month. And then October 20th, 20 plus 7 is 27. So her due date is going to be July 27th next year. This is a pregnancy wheel. This is another way we tell when her due date is. It's also based on the first day of her last menstrual period. We say that it's 40 weeks. So 40 weeks gestation. It's just a guess. And so it's just a guesstimate of when she's going to be due. And you hear that some people baby come early and some people's babies come late. It's just a guesstimate of when her baby's going to be due, which is dependent on her last menstrual period. And so these pregnancy wheels, as you can see, it says February, March, April, and you see the numbers, and those numbers under April are the days. And so every day that a baby is inside in utero is a good day. And so we're going to give them credit for every single day that they're pregnant. So if she says that her last menstrual period is in April, and we calculate to when her due date is, we're not going to say that it's due in January 20th and a half, right? We always give a day. And so if we say today she's 37 weeks, we're not going to say 37 and a half weeks. We're going to say 37 and 3/7 days. And then at midnight, the clock changes and it's going to be 37 and 4/7 days. So every day the baby's inside is a good day. So a term pregnancy is considered over 37 weeks. So 37 weeks and 0/7 and on is term. And so if she is between 20 weeks and 36 and 6/7 days, that would be considered preterm. 20 weeks is half of her pregnancy. So she's 5 months pregnant at 20 weeks. If a woman delivers a baby under 20 weeks, it's considered a miscarriage, but in the hospital, it's called an abortion, even if it's not an abortion. And so they use those terms interchangeably. So over 37 weeks, 37 and on is term. Under 37 weeks down to 20 weeks is preterm, and then under 20 weeks is a miscarriage or abortion if she delivers. And these are for deliveries. So when we look at pregnancy, when our patients come in, we ask them a bunch of questions. We want to know when their due date is, because we're going to look at that pregnancy wheel to determine if they're term or if they're preterm. And then if we are, we're going to ask how many babies they've had. And we have acronyms for our to tell how many babies that she has had or if she's had any. So we do what's called the GTPAL. So G is gravida, and that means how many times you've been pregnant, gravid, your belly is gravid. So how many times have you been pregnant? So that's the G. T is how many of those pregnancies are term. So how many, when you delivered, how many of your babies were 37 weeks and over? How many of your babies were preterm for the P? That's the number of preterm deliveries, and that's between that 20 weeks to 36 and 6/7. A is the abortions. It could be a miscarriage or an abortion, and it's under 20 weeks. And L is the number of living children. So we'll ask her what her GTPAL is. So we ask her every one of those questions individually to figure out if this is her first baby or if she's had lots of babies. So we write it on the chart as GTPAL, and you can see my example. She's G4, so that means she's been pregnant 4 times. T1, she had 1 baby that was delivered over 37 weeks. P1, she had 1 baby that was delivered under 37 weeks. A1, she had 1 miscarriage or abortion. And L1, she has 1 living child. So if she was going to be picked up by the paramedics or somebody was talking to her in the community, they might say, what is your G's and P's? And so G is the same as it is for the GTPAL. G is gravida. How many times have you been pregnant? And P is how many times have you delivered? So it can be written as G and P. So G4, she's been pregnant 4 times. She's had 3 deliveries. All right, so let's practice. So get ready to write this down and see if you know the answer. So Angela arrived to labor and delivery in labor at 39 weeks gestation. She told you that she's had an abortion at age 18. She's lost a baby at 17 weeks gestation, and she had a baby at 36 weeks and a baby at 40 weeks. Her children are 3 and 5. So what is her GTPAL? And one thing that students forget is Angela arrived to labor and delivery in labor. So we always have to count that one. Sometimes students forget to count why she came there. So think about her gestation and how many times she's been pregnant and see if you can figure it out. And I'll give you just a minute. All right, so Angela arrived to labor and delivery. So that's one pregnancy. She's 39 weeks gestation. She told you she had an abortion. That's 2 pregnancies. She lost a baby at 17 weeks. That's 3. She had 1 at 36. That's 4. And she had 1 at 40 weeks. That's 5. So she's G5. One of her babies was term because she delivered at 40 weeks. One of her babies was preterm because she delivered at 36 weeks. And she had 2 abortions. She had 1 when she was 18, and she lost a baby at 17 weeks. So that's 2. And then she has 2 living children who are 3 and 5. Did you get it right? Let's practice again and see if you get this one right. So Susan arrived to the clinic for her prenatal appointment. She stated she had a baby at 28 weeks when she was 18. She had a delivery at 18 weeks, twins at 35 weeks, and her children are 4 and 7. What is her GTPAL? Okay, so Susan arrived at the clinic, so that's 1. She had a baby at 28 weeks, that's 2. She had a delivery at 18 weeks, that's 3. And she had twins at 35 weeks, that's 4. So when you have multiple babies inside there, twins, triplets, quadruplets, that only still counts as 1 pregnancy. So she had no babies at term, so she had no babies over 37 weeks. She had 2 preterm deliveries. She had a 28-weeker and 35-week baby, and she had one abortion at 18 weeks, and she has twins who are 4 and a 7-year-old. Okay, so she has 3 living children. So she gets credit for her multiples when in her living part of her GTPAL. All right, so how many of you have seen a fetal monitor, visited someone in the hospital? So we put a patient on the fetal monitor because we have a patient we can see who's the mom, and we have a patient we can't see who's the baby. So when she walks in to labor and delivery and is pregnant, we want to make sure we know that the baby is doing okay. So we'll put her on the fetal monitor, and you can see that's the fetal monitor right there. The normal fetal heart rate is 110 to 160. 110 to 160 beats per minute. So that's normal. Our pulse runs about 70 to 80, maybe even 90, but the fetal heart rate is 110 to 160. When the heart rate in the fetus is over 160, it's called tachycardia. And when it's under 110, it's called bradycardia. The fetal monitor, you can see she has these cords attached to this monitor, and then she's got 2 straps on her belly. The top strap that she has on her belly, that monitor is monitoring her contractions, because that's the top part of her uterine muscle. And the uterine muscle is the top part, the most strongest part is called the fundus. And so that's where we see the contractions. So that's where we would put the contraction monitor. The monitor that's lower on her belly is called the sono. It's like an ultrasound. And we put some gel on there so that we can have a conductive, like medium, so we can pick up the heart rate. And we put that monitor right at the level of where the baby's back is, because that's where the heart is. And then we're able to figure out what the heart rate is, and we can actually see it on the monitor. If you look on the monitor, you can see paper coming out of that monitor. That has the fetal heart rate on that paper, and it has her contractions on that paper. So contractions are the hardening of the uterine muscle. You can see that person touching the top of the patient's belly. She's touching the fundus. She's filling out where the fundus is and how strong it is. And so patients really don't know what contractions feel like if they've never had a baby, and they feel like menstrual cramps. They get stronger, they come and go, they start getting more painful. And we palpate or touch the mom's belly at the fundus to feel how strong the contractions are. So I'm going to show you how we tell by feeling. And so if you touch the tip of your nose, everybody touch the tip of your nose. That's what a contraction feels like when the belly tightens up, and it's a mild contraction. And so that's just like a cramp. It's not going to be like a labor contraction. Everybody touch your chin. Okay, touching your chin, this feels like a contraction that's moderate strength. And we like contractions to be stronger if she's going to be in labor, because that's what pushes the baby downward. And then if you touch your forehead, everybody touch your forehead. This is what a contraction feels like that's strong when we touch it. So the contraction will build up and get strong, and then the uterus will relax and it won't feel hard anymore. And when we see a contraction on the fetal monitor, they look like hills. Okay, this is a fetal monitor strip. And if you look at the numbers 30, 60, 90, 120, that's where the fetal heart rate goes. And do you remember what I told you the normal fetal heart rate is for a fetus? It would be 110 to 160, and you would see it, little squiggly lines in there between 110 and 160. The bottom part of the monitor is where the contractions go, and those are going to look like hills. And so I'm going to give you a little case study, and we're going to see what we see, if you can figure out what's going on with her. So we have a 27-year-old patient. She's 39 and 1/7 weeks gestation, so she's term. She comes to labor and delivery. We find out that she's a G3, so 3 pregnancies. She's a T1, one of those was at term. She's had P1, she had a preterm baby. She's had no miscarriages or abortions, and she has 2 babies. She came in for a labor check. So what that means is she comes in because she thinks she's in labor. She's been having contractions every 5 minutes for 2 hours. She's not leaking any fluid, which would be her bag of water, or she's not having any bleeding. She states she feels her baby move, and we like when they feel their baby move. That's a good sign. The patient is placed on the fetal monitor to evaluate the fetal heart rate and look at her contraction pattern. UC is uterine contraction. So when we check our patients, you probably heard your people say, oh, you need to be 10 centimeters to have a baby. You do need to be 10 centimeters. And I'll put that in perspective for you. So if you see that bagel on this chart, that bagel is 10 centimeters. That's how open the cervix needs to be before she can have a baby. And so if you look at what 1 centimeter is, that's a Cheerio. And so as her cervix thins out, that's called effacement. The cervix is about a couple inches long. It gets thinned out and it opens, and then the baby moves downward. And then you might hear the word station. And so as far as a fetal station, that is the baby getting lower toward you. This is your fetal heart rate tracing strip. Okay, so your little case study, we put your patient on the monitor. You see the blue line across, that's 110 to 160. That line shows you where the fetal heart rate should be. It's normal for the fetal heart rate to fluctuate up and down. We like that. When you take a deep breath, your heart rate goes up, and when you let that breath out, your heart rate goes down. So your heart rate doesn't stay 70 or 80 all the time. It kind of goes up and down. As you can see down below, those hills, those are contractions. And so as we look at these contractions, this dark pink line to this other dark pink line, that's a minute. So she's having this contraction. And as you look at each little box is 10 seconds. So her contraction is lasting, if we count, 1, 2, 3, 4, 5, about 60 seconds from the beginning of where it starts to the end. This is the strongest part of the contraction at the top. This is called the peak. And this is where, when we feel our nose, our chin, and our forehead, we're feeling this top part of the contraction to see how strong it is. So this baby's heart rate looks good. We like how it looks. You can see how it fluctuates. Even though it goes above 160, that's okay, because it's normally in between 110 to 160. Okay. So in reviewing our tracing, we saw that our heart rate was 150. So we'll go back and you can see the heart rate here is 150, where it hits the most at 150. Oops. She has what are called accelerations. That causes the baby's heart rate to go up. It gets excited. We like accelerations. Decelerations, that's where the heart rate goes down. We didn't see the heart rate go down. And we put our fetal heart rate tracing in categories. We give them 3 categories, 1, 2, and 3. 1 is really good, 3 is really bad, and 2 is we're just watching our patients. We're looking at her contractions. So let's go back. She had 3 contractions. We look in a 10-minute period. So we're going to say this is 10 minutes. So she had 3 contractions in 10 minutes. We would say how long they're lasting. So we would count from the beginning of the contraction to the end of the contraction. And we ask our patients, how long are your contractions lasting? And they'll tell you about a minute or so most of the time. When we touch her contractions, we palpate it, it felt mild, and then it relaxed to soft. We did a vaginal exam on her and found that she was 1 centimeter dilated, 50% effaced, and -3 station. So what this means is that 1 was the size of a Cheerio. So a baby can't come out of a Cheerio. So she's not in labor. Her cervix is halfway thinned out. That's what 50% means. And then -3 means the baby is not moving down into closer into the pelvis. And so whenever we see a minus number for the station where the baby is, that means the baby's not near you, it's away from you. When we hear a plus number, that means the baby's coming toward you and on the way out of her vagina. So we sent her home because this patient's not in labor. And this happens all the time where patients will come in thinking that they're in labor and they're not in labor, and then we have to send them home, even if they feel their contractions hurt. For labor, pain is subjective. And what that means is everybody has their own idea of what's painful. And some people can get a paper cut and want to call an ambulance and say, oh my gosh, this is killing me. This hurts so much. And some people can like rip their arm off and be like, oh, this is a little uncomfortable. So pain in labor is a perception, it's subjective. All right, so how many of you think that the nursing profession is for you? What do you think you need to do to become a nurse? So there's different things you can do to become a nurse. Let's see who wants to be a nurse. Okay, good. So we have RNs, we have PAs, we have MDs and DNPs. Good. Okay, and when you get in one direction, you could change your mind. I have friends who decided that they wanted to be a doctor and instead became a nurse because they wanted to spend more time with their patients. I've had friends who wanted to be a nurse, who became a nurse and then went back to medical school and became a doctor. And so your career can change, your ideas can change as you get into it. So if you decide that you wanted to be a nurse, you want a Bachelor of Science in Nursing, here's some of the prerequisites. You would have to check with wherever institution you plan on attending, but you would be required to have English classes, algebra, statistics, oral communication, lifespan development, chemistry, organic chemistry, anatomy and physiology, microbiology. The TEAS or HESI exam also needs to be done prior to application into the nursing program. If you are someone who already has a bachelor's degree in something else and you decide, hey, nursing is for me, I want to change my profession, there's also programs that are called like entry-level masters, where you have a bachelor's degree in something, and then you decide you're going to go into nursing school. So you wouldn't get a bachelor's degree, but you would get all your pre-licensure nursing education, and then you would be done with that, get a nursing job, and then continue to your master's in nursing. And so there's lots of options. Lots of people have ideas of what they want to do. They get in it and they love it, or they get in it and they veer to another direction. So advice or tips. I would recommend that you make a list of potential professions that are interesting to you. When you find a profession that you love, when you go to work, it's not work. It's enjoyment, it's satisfaction. So you'll never work a day in your life if you love what you do. So you want to make a list. What do you think fits you? What is interesting? What sounds interesting? I would write the pros and cons of each profession. In nursing, you can count on the fact that you're going to work holidays and weekends, and maybe night shift. You could ask to shadow or interview people in those professions and ask them the pros and cons of their professions, things they love about it, things that are interesting, things that drew them to that direction. You could take a professional questionnaire or a career quiz to see what you match with. If you do decide that you're going to go into the healthcare field, it's a good idea to do really well on your science courses, because that impacts it impacts how you are moving forward. And those who do well in the science classes tend to do well in the health science classes. Volunteering is very good, getting exposure to patient care, to clinics, to hospitals. It helps you with patient interaction, so you're not so scared when you have to do clinicals. You could work at a hospital or clinic. This is a good level of experience also for you. This will help you understand the routines and the interactions amongst the different healthcare providers. And then take your time. Don't be in a rush on where you want to go. Really think it out, because once you start school, you start committing to what you want to do, and you don't want to get all the way through that degree and decide, oh my gosh, I can't stand this. So really think about it. Think about what you like. Talk to people. You might know people. Just because someone in your family decides to go in that direction doesn't mean that you have to. And so you want to go with what interests you, because that might be the career that you decide to go for the rest of your life. Do you have any questions for me?
We can go ahead and move on to the Q&A portion and look at some of the questions people have dropped in the chat.
Okay.
So Jada is asking how difficult it is to transition between the specialties as a nurse. So you mentioned that you were in the ER and then moved to OBGYN.
Okay, so that's the great thing about nursing, is that you can decide that this area isn't for you, and then you can apply and move to another area. And so it's not that difficult. And what you're bringing with you are your previous experiences. So when I went from surgical trauma ICU to ER, I had experiences with those patients who had critical issues. And so it's not that hard. When you're a physician and you say, I'm going to do ortho, that's what you commit to do. But as nursing, you get to move around and decide what fits you the best. That's a great question.
Yeah, thank you. Nina is asking, what's the hardest part about your job as a nurse?
The hardest part about my job is the sad days when patients lose their babies. And that's the toughest part, because you're their support person, you're taking care of them all day, you're answering their questions, you're providing emotional care. So that can be very trying. And when you're a nurse sometimes, or in any healthcare provider, when you have sad times, you have to remember not to take it home with you. And so that can be difficult.
Yeah, I can imagine that. Meso is asking do you think you learned more about humanity as you spent time with many families of different ethnicities and religious backgrounds, and seeing families just have a new human being in their lives?
Yes, that's a really good question, because as nurses or any healthcare provider, you need to be culturally aware. You need to be asking, do you have any cultural practices you want included in your care? Do you have any religious practices you want included in your care? And if you're not familiar with their culture or their religious practices, you ask. And I think it's very important, because you give better care when you're aware of their needs and expectations. That's a really good question.
Yeah. Scarlett asks, what kind of areas are you allowed to work in as a new grad nurse? For example, are you allowed to work in labor and delivery just as a new grad, or do you need more experience?
You are. The nice thing about it is that many areas have what's called a new grad residency. And so you're hired as a cohort with other new grads, like 5 or 6, to a unit. They give you so many months of orientation, and then they monitor you for a year. And a lot of places will have like a little graduation. You graduated from your residency. And so it's not difficult to go into specialty areas anymore. When I was a new grad a long time ago, they didn't have those programs. But now with the residencies, it allows the new grads to go into whatever area they want with a lot of support. Good question.
That's great that people can go to where their interests call.
Yes.
So we have some questions regarding like some things that you've addressed in your presentation.
Okay.
Jada is asking, why is the normal fetal heart rate higher than an adult's heart rate?
Well, the baby's smaller, and so the heart rate is faster. And as the person gets older, the heart rate starts slowing down. And so that's just the normal heart rate for that baby. What happens is, without going into great detail, you have a parasympathetic and a sympathetic that work together, and that's what makes the heart rate go fast or slow. And so for babies, it's faster. And like I said, as you get older, the heart rate starts slowing and you get bigger. Good question.
Yeah, that's so interesting. Siri is asking, what if a woman doesn't remember the last day of her menstrual period when the doctor or nurse asks them?
Okay, so what they can do is an ultrasound, and they can see, depending on how far along she is in her pregnancy, if they'll measure. And most fetuses are the same size until they're 20 weeks. So until they hit 5 months, and then they all start growing on their own like trajectory. So that's why you have some babies who are 6 pounds and some babies who are 10 pounds, but most of them are about the same size till they're about 20 weeks. So they can measure them with the ultrasound and see what the ultrasound says by how many weeks and days gestation the fetus is.
That's interesting.
Mm-hmm.
Some of the audience members are wondering if you have done any research in your student life or just now, and what kind of research were you involved in, if it was directly related to your field that you're working in now or just completely different.
Okay, so I did some research on preconception health education. I researched health science students to see what they knew about preconception health. And that's what I wrote my paper on, and found out that a lot of students, depending on their ages, really didn't know much about preconception health, the importance of getting the body ready for pregnancy, even if you're not planning on getting pregnant, because 50% of pregnancies are unplanned. And so want to make sure that those males and females who are in childbearing ages are getting their body healthy just in case a pregnancy occurs. So I did research on that.
Great, thank you. Speaking of the preconception pregnancies, are there any procedures or processes that happen when a baby is born with a birth defect?
Yes, it depends on the birth defect. So I work at a high-risk facility. So if we know about birth defects, we will have the neonatal intensive care team come to our deliveries, and they may deliver the baby, or they may take the baby to their unit. And so if you have prenatal care, you've been checked out, they'll know what's going to happen at their delivery based on the problem or issue that the baby has when it gets here. You guys got good questions.
Yeah. Another student is asking, why did you become a nurse and an educator? And just describing how you balance both of those kind of professions, and also how accommodating was your nursing job when you were returning to school?
Okay, so let me start with the last part. A lot of the hospitals will offer continuing education to their nurses. And so they will pay for you to have continuing education. And so they were very supportive of me going back to school. I only took one class at a time because I had children. I was working full time, and that's how I completed my master's. So they were very supportive. When I did my student teaching at the university, that's when they offered me a job when I was done. And so I decided that I wanted to do that. So I quit working full time on labor and delivery and just went per diem. So I work a couple of days a month. My current job that I teach, because I teach OB, they're very supportive of me going and doing some clinical shifts, because that's good for my students. It's good for me to tell stories about what I saw in clinical practice, because my students are in clinical in the OB setting, and they want to talk about what they saw and why they saw it. So it helps us connect with each other. So the job is very supportive. I love education. I've worked at a teaching hospital my whole career. So when you work at a teaching hospital, there's med students, nursing students, respiratory students, there's all kinds of students everywhere. So I've been exposed to students my whole career. And I love to teach, because when you work at a teaching hospital, you get to take students. And so I've been doing that a long time. And so I get the best of both worlds by being able to take care of patients and be with students who are going to be taking care of patients someday.
Yeah, it's always interesting to learn how flexible careers can be, and you can kind of switch things around to see to meet your values in your
Right.
life. So Mariam is asking, what is the most hands-on experience a high school student can get, since they are high school students, so they don't have the training to get like all of the hands-on experiences. So what do you think would be a good idea if she wanted to get hands-on experience?
So there's classes that you could take. You could ask for shadowing. Some of the hospitals will let high schoolers shadow. I've had some high school shadows. Volunteering at the hospital, that is really good, because then you get more exposure to the students. You're sent to various areas. You see different things. You're helping people. And this gives you a good idea of what you'd like to do. And you get to watch the nurses and other healthcare providers care for patients. And so you get exposed to it, and that will help. Also, what you can do, I know some high schools have those health programs where they give you certifications. That would probably be another method if your high school does that.
Awesome. I hope Mariam does what you've told her about the hands-on experiences. So if you do encounter obese patients in your profession, is there a standard approach that you use towards them? And do you think the risks erasing the unique body chemical makeup of obese patients who attribute their health issues to chronic diseases rather than lifestyle choices, as most people assume? Because we do know that there's a higher risk of having birth defects and just the baby's health in general due to obesity, like gestational diabetes. So how do you just deal with obese patients?
Well, we treat them like everybody else, right? And so everybody has things about them that may be an issue, right? And so we like everybody to be compliant. And just because a patient's obese doesn't mean that they're not going to lose weight in pregnancy. Sometimes our patients will say, oh my gosh, I'm pregnant. I got to start eating healthy and getting my health under control. And they lose weight during pregnancy. Sometimes, 50% of pregnancies are unplanned. Maybe they didn't plan it, but you just treat them based on their condition, and you encourage them to promote the health of their baby. You can have thin people who are diabetic. If they're diabetic, they're at risk of having a larger baby. So we like to encourage them to get their blood pressure under control and their blood sugars under control. If they didn't do it before pregnancy, we encourage them to do it during pregnancy.
Thank you for that awesome answer. So another audience member is asking, how do you keep learning as a professional? This is kind of, how do you just refresh your knowledge base and just learning new information? Do you read certain books, listen to certain podcasts? What do you do to keep learning?
That's a good question. As an adult, you're always going to be a learner. Okay. And I learn something new every day. I learn through the eyes of my students. I do read and listen to journals. Part of having a nursing license is that you have to do continuing education credits. You have to turn them into your Board of Registered Nursing every 2 years. So that's a requirement that you keep moving as far as your education goes. And then you have certifications. So I have certifications that I renew every couple years. And so that's another educational opportunity. I think it's important to keep learning regardless of the area that you choose to go into. You should always be willing and trying to learn more.
Yes, I definitely believe in that. Jada asks, is there a difference between working in obstetrics versus gynecology? And are they just same?
Okay, so gynecology is women who are not pregnant. Obstetrics is women who are pregnant. And so if you went to your OBGYN, that provider is one who sees you while you're pregnant and sees you when you're not pregnant. And so the two are completely different. So gynecology is women's health issues, and obstetrics is pregnancy.
Thank you for the clarification. How does one know if a nursing career is right for them?
Okay, I would go ahead and make those pros and cons. I would look into nursing. If you know people, you can interview them. We encourage any student who's thinking about being a nurse to ask others, because they're going to give you a good perspective. If you just read it off the internet, you might not have all the ins and outs of what the career has to offer, or, you know, the upsides, the downsides. But if you talk to someone who does it, they can give you different perspectives and encouragement.
Thank you for that answer. There was one last question we were asking. Is MSN the same as nurse practitioner, or are they different?
They're different. So nurse practitioner is a nurse who practices like in a clinic, or she may work at a hospital. He or she may work at a hospital, but they're a practitioner. I'm not a nurse practitioner. I am a nurse with a master's and a doctorate. So I have a master's degree in nursing education. So the two are completely different. I don't provide advanced practice like a nurse practitioner.
Awesome. Do you have any last advice for our students here who are looking to get into nursing?
I do. And so depending on where you go, there are different opportunities. You can be an associate degree nurse. So you can get that degree at a community college. You can get a bachelor's degree at a university or a state college. Or you can have an advanced degree, a nurse practitioner, nurse midwife. You can get your master's and do education, informatics, leadership, or you can get your doctorate. So I said I had a doctorate of nursing practice. You could also get a PhD. And so there's different things that you can think about depending on what you want to do. And so I would just look into it, see what fits you right now. If you start with the associate degree, you may move on to a bachelor's degree or a master's. It just depends what you're looking for.
Thank you for that answer. I hope everyone uses the advice she gives us. It was such a brilliant presentation. Thank you so much for that informative presentation. We really appreciate it. So considering this, we would like to encourage everyone to reflect on today's session today. What brought you to the session today? What are 3 major takeaways you got? And what do you want to learn more about? This writing a reflection is not required. However, we encourage you to submit it to our website for publication and recognition for your hard work, and to enhance future applications. So if you see on the screen here, you can go on to www.prehealthshadowing.com/blog submissions to submit your reflections if you choose to do so to get published. If you want to learn more about pre-health shadowing and get involved in our program, we encourage you to visit our website. You can become an asynchronous volunteer to get certified hours through professional nominations, graphic design, and social media promotion. We are also accepting team member applications if you want to take on a more active role and lead the numerous projects and initiatives we have, and even be up here with us co-hosting the sessions. Once again, we are humbly asking that if you are financially able to, that you please consider donating to Pre-Health Shadowing via Venmo or PayPal. It does cost a lot to keep our program up and running and free to all of you. So if you can't afford it and know someone who can, please share the message and support this nonprofit organization. Otherwise, we simply ask you to spread the word about Pre-Health Shadowing so we can reach as many students as possible and offer this virtual opportunity during a pandemic. So now for the part we've all been waiting for, how to earn your digital certificate for the virtual shadowing hours from this session today. Go on to our website and find our professionals course pages. And next, you can take our quick 10-question multiple choice quiz based on the content from the session today. So you will have 30 minutes per attempt, and you will be getting 2 attempts and your goal is to get a 70% or higher to get your certificate. We know that technology can be difficult sometimes, so we recommend waiting 30 minutes to an hour after the session because there's usually a high influx of students waiting to take the quiz. And the quiz will be open indefinitely, so you can take it next week or next month if you so choose to. So once you have passed, you can click the Finish Course button at the bottom of the Professionals page and download your certificate verifying your virtual shadowing hours. If you did happen to miss a part of the session or just want to go back and refresh your memory and view all the other sessions we had in the past and earn more certificates with verified virtual shadowing hours, you can go onto our YouTube channel where we have recorded previous sessions. You can also find them via the Professionals page on our website and take the post-shadowing assessments on any of the sessions if you choose to. So be sure to follow us on social media. We have our Instagram and TikTok page, and we are currently booked every weekday through June for virtual shadowing sessions. So I hope to see you guys there. Thank you guys for joining today. Please stick around if you have any questions for myself and other team members. We will be happy to answer them. The shadowing session is officially over. I invite everyone to log off, and thank you so much, Dr. Thompson, for being here today.